There's a pill sitting in medicine cabinets all over the world right now, millions of them, swallowed every single morning without a second thought. And here's the unsettling part. Most of the people taking it have no real idea what it's actually doing inside their bodies. If you've ever been handed this prescription or you've been taking it for years, I promise you, by the end of this video, you'll know more about it than most doctors have time to explain in a 7-minute appointment. And stick with me until the very end, because I'm going to reveal one habit, completely free, taking less than 15 minutes a day, that clinical research shows can outperform this medication at controlling your blood sugar, not slightly outperform it, genuinely outperform it. This isn't hype. This is what the actual data says. So let's get into it. An emergency medicine doctor, and I spend my working life watching the end stage of diseases that could so often have been prevented years earlier. This channel exists to close that gap, to give you the information before the crisis, not after it. Today we're talking about metformin. If that word means something to you personally, you are far from alone. Let's start with where it even came from. Metformin isn't some new pharmaceutical invention. Its origins trace back to a flowering plant called French lilac, historically used in European folk medicine centuries ago to ease symptoms that we now recognize as diabetes. Scientists eventually isolated the active compound, refined it, and turned it into the medication we know today. It now sits on the World Health Organization's list of essential medicines, the drugs considered most critical to a functioning healthcare system. It's inexpensive, it's everywhere, and in most countries it is the very first medication offered to someone newly diagnosed with type 2 diabetes, which means if you're taking it, you're in the company of tens of millions of people worldwide. And yet, time and again, I meet patients who've been taking it for years without ever understanding what it does, why it works, or what they could be doing alongside it to get dramatically better results. That's what today is about. Before we talk about the drug, we need to talk about the disease. Because once you understand the disease, the drug makes perfect sense. When you eat carbohydrates, your digestive system breaks them into glucose, which enters your bloodstream. Your pancreas senses that rise and releases insulin, a chemical messenger that tells your muscles and liver to absorb that glucose and clear out of the blood. In type 2 diabetes, that messaging system starts to break down. Your cells become resistant to insulin signal. They essentially stop listening, usually because blood sugar has been running high for a long time already. Your pancreas tries to compensate by producing more and more insulin, shouting louder to get the message through. Eventually, it can't keep up. Blood sugar stays elevated. And this is where things get serious, because chronically high blood sugar is quietly corrosive. It damages the small blood vessels in your kidneys, contributing to kidney failure. It damages the blood vessels in your retina. It's one of the leading causes of preventable blindness in working-age adults. It damages nerves in the feet and hands, causing pain or numbness. And it accelerates hardening of the arteries, roughly doubling the risk of heart attack and stroke. The blunt reality: people with poorly controlled type 2 diabetes die, on average, about a decade earlier than they otherwise would. I'm not telling you this to frighten you. I'm telling you because understanding the stakes is exactly what motivates people to take control. And here's the genuinely good news: none of this is fixed. Every one of these risks falls as your blood sugar control improves. That's the entire goal of everything we're about to discuss. Here's something that surprises most people. Metformin's main target isn't the pancreas, and it isn't your blood sugar directly. Its primary action is in the liver. Your liver constantly trickles glucose into your bloodstream between meals, acting as a background fuel supply, so your brain and body keep running even when you haven't eaten. In type 2 diabetes, that background release goes into overdrive. The liver keeps pumping out glucose even when levels are already too high. Picture a tap that won't fully shut off. Metformin's job is to turn that tap down. It does this by activating an enzyme inside liver cells called AMPK. Think of it as a master energy switch. Once activated, it signals the liver to dial back its glucose output. Less glucose pouring in from the liver means lower blood sugar overall, and particularly a lower fasting reading first thing in the morning. Beyond the liver, metformin also makes muscle cells somewhat more responsive to insulin. So whatever insulin your body does produce works more effectively, and it slightly slows glucose absorption from the gut after meals. It's working on multiple fronts simultaneously, all pushing in the same direction. And crucially, it does this without artificially forcing blood sugar too low. It works with your body's existing systems rather than overriding them, which is exactly why it has such a strong safety record and why it's the default first choice worldwide. Metformin is almost always started at a low dose, typically 500 milligrams once daily, and increased gradually over several weeks. That slow buildup isn't because the drug needs time to activate. It's specifically to minimize digestive side effects, which we'll get to shortly. Most people eventually settle somewhere between 1,500 and 2,000 milligrams daily, usually split across 2 or 3 doses taken with food. Taking it with meals matters. It slows absorption and significantly cuts the risk of stomach upset. One important thing to know, you won't feel this medication working. There's no sensation, no obvious day-to-day change. The only real feedback comes from blood sugar monitoring and from a test called HbA1c. Understanding HbA1c, this is a test that will shape your entire diabetes care, and it's rarely explained properly. HbA1c measures glycated hemoglobin. Hemoglobin being the protein inside red blood cells that carries oxygen. Glucose circulating in your blood gradually attaches to that hemoglobin, and the more glucose present, the more sticks. Since red blood cells live roughly 2 to 3 months before being replaced, the amount of glucose attached to them gives a reliable average of your blood sugar over that entire window. Unlike a single finger prick reading, which can be thrown off by a bad night's sleep, a stressful morning, or an unusual breakfast, HbA1c smooths all that out into an honest long-term picture. The units differ by country, which causes a lot of confusion. In the UK and much of Europe, it's measured in millimoles per mole. Normal is below 42, prediabetes sits between 42 and 47, and diabetes is diagnosed at 48 or above. In the US, it's expressed as percentage. Normal is below 5.7%. Prediabetes is 5.7 to 6.4%, and diabetes is 6.5% or higher. After starting metformin, your doctor will typically recheck this around the 3-month mark, then roughly every 6 months after that. The goal is getting you back under the diabetic threshold, and the evidence suggests that even within the normal range, lower is generally safer. This is usually what people are most anxious about. The most common issue is gastrointestinal, nausea, cramping, bloating, or diarrhea. Studies suggest around 20 to 30% of people experience some degree of this, particularly in the early weeks. The encouraging part is that for most people, it settles significantly as the gut adjusts. Increasing the dose slowly and always taking it with food makes a real difference here. If symptoms persist despite that, there's a modified release or extended release version of the drug that releases more gradually and tends to cause far fewer digestive symptoms. Many long-term patients end up on this version. Same effect, gentler on the stomach. And it's absolutely worth asking your doctor about if you're struggling. One more thing worth repeating clearly. Metformin does not cause hypoglycemia on its own. Symptoms like shakiness, cold sweats, dizziness, or a racing heart are caused by medications that actively force insulin release or push blood sugar down regardless of context. Metformin doesn't work that way. It brings elevated blood sugar down toward normal, but it won't push it below normal by itself. That's a big part of why it's the trusted first-line choice. 2 major studies are worth knowing about. The first is a landmark British study following thousands of newly diagnosed type 2 diabetics over many years, examining whether tighter blood sugar control actually reduced serious complications. It did. But the standout finding specifically for metformin was that in people who were overweight, it reduced heart attacks and diabetes-related deaths more than other glucose-lowering treatment, even when blood sugar control was similar. That suggests metformin does something protective beyond glucose numbers alone. The second is a major American trial that studied people with prediabetes, blood sugar that's elevated but hasn't yet crossed into the diabetic range. It compared metformin against an intensive lifestyle program involving dietary change and around 150 minutes of moderate exercise per week. The lifestyle group cut their risk of progressing to full type 2 diabetes by 58%. Metformin's group achieved a 31% reduction. Lifestyle won by a wide margin. Keep that number in mind, because we're coming back to it. Vitamin B12, something rarely discussed enough. Long-term metformin use can interfere with the body's absorption of vitamin B12, which is essential for nerve function and red blood cell production. Deficiency can build slowly and silently, eventually causing fatigue, tingling or numbness in the hands and feet, or problems with memory and concentration. Symptoms easily blamed on other things. Current guidance recommends periodic B12 checks for anyone on long-term metformin. If you've been on it for years and can't remember ever having this tested, it's worth raising with your doctor. It's a simple blood test, and if levels are low, supplementation is straightforward and effective. This isn't a reason to avoid the medication. The benefits far outweigh this manageable risk, but it's worth knowing. Kidney function. You may have noticed kidney function mentioned on your prescription leaflet or by your doctor. Metformin is cleared from the body through the kidneys, so if kidney function is impaired, the drug can build up. In rare cases, this can lead to a serious condition called lactic acidosis, a dangerous accumulation of lactic acid in the blood. This is rare, so there's no need for alarm, but it's exactly why kidney function is monitored regularly. If your kidney readings drop below a certain threshold, doctors will reduce the dose or stop the medication temporarily. The same approach used with many other drugs cleared through the kidneys. The key is simply attending your checkups and telling your doctor if you become unwell, dehydrated, or are scheduled for a scan involving contrast dye, since metformin sometimes needs to be paused around those situations. Here's something that needs to be said plainly, because it changes how you should think about your own health going forward. Metformin manages your blood sugar number. It does not reverse the underlying cause of type 2 diabetes. In most cases, type 2 diabetes develops in the context of excess body fat, particularly fat stored around and inside internal organs, combined with inactivity, a diet heavy in processed and refined foods, and in some cases genetic predisposition. Those root causes remain in the background unless you actively address them. The medication doesn't touch them. And this is what makes type 2 diabetes genuinely different from many chronic conditions. With serious lifestyle change, real remission is possible for some people, not just improved lab numbers, but blood sugar returning to fully normal levels without medication. It doesn't happen for everyone, and it requires real, sustained effort under medical supervision, but it is documented, real, and increasingly well-studied. The medication and lifestyle change aren't competing options. The people who do best long-term take both seriously. Remember that pre-diabetes trial, lifestyle change beating metformin, 58% versus 31%? A separate, landmark UK study looked at people who already had established type 2 diabetes, some for as long as 6 years, using a structured low-calorie approach followed by carefully guided food reintroduction and ongoing support. 46% of participants achieved full remission within 1 year. At the 2-year mark, a third remained in remission. The biological explanation makes complete sense. Significant weight loss, particularly loss of fat around the liver and pancreas, directly reduces insulin resistance and can restore more normal insulin production. The liver stops overproducing glucose. The whole system starts functioning properly again. You don't need a specific named diet to move in this direction. The evidence consistently points toward reducing overall calorie intake, cutting back on ultra-processed foods and refined carbohydrates, prioritizing vegetables, legumes, whole grains, and protein, and staying physically active. If your healthcare provider offers a structured diabetes management program, take it seriously, not as an optional add-on, but as something with equal or greater power to change your trajectory compared to the tablet alone. Now, the thing I promised you at the start, walking after eating. I know it sounds almost too simple to matter, but the research behind it is genuinely striking. A study published in a sports medicine journal found that short walks taken immediately after meals produced a significantly greater drop in post-meal blood sugar than a single longer walk taken at a different time of day, such as first thing in the morning. Even 10 to 15 minutes made a measurable difference. Timing is everything here. When you eat, glucose floods your bloodstream. If you walk during that exact window, your contracting muscles pull glucose directly out of your blood without needing insulin to do the work. It's one of the very few mechanisms your body has for clearing blood sugar independently of insulin, which makes it especially valuable if you're insulin resistant. Even a 10-minute walk after each main meal adds up to about 30 minutes a day of targeted blood sugar management, time precisely when it matters most. If you want to go further, pair this with 2 additional simple changes. First, eat protein and fiber before carbohydrates. Research shows that eating vegetables and protein first, saving starchy carbs for later in the meal, can reduce post-meal blood sugar spikes by roughly 30 to 40%. Same food, same calories, just a different order. Protein and fiber slow gastric emptying, so glucose enters your bloodstream gradually instead of all at once. Second, prioritize fiber overall. Large-scale research consistently links higher dietary fiber intake with lower HbA1c and fasting glucose. Fiber slows glucose absorption, feeds beneficial gut bacteria linked to better insulin sensitivity, and reduces the overall calorie density of meals. None of this replaces metformin. None of it replaces conversations with your doctor. But 3 times a day, Every single day, you have a genuine opportunity to influence your blood sugar in a way that's measurable, meaningful, and costs absolutely nothing. So let's bring it all together. Metformin is one of the safest, most studied, and most trusted medications in modern medicine. It works primarily by reducing the liver's excessive background release of glucose and by improving how effectively your cells respond to insulin. It's taken with food, started low, and increased gradually. The most common side effects are digestive, and a modified release version exists if those symptoms don't settle. It does not cause low blood sugar on its own. If you've been on it long term, get your B12 checked, and don't skip your kidney function monitoring. And understand this clearly. The tablet, however effective, is managing a condition whose roots lie in lifestyle factors that no medication alone can fix. The evidence shows remission is genuinely possible. The evidence shows lifestyle intervention can outperform the drug itself. And a 10-minute walk after each meal, eating protein and fiber before carbohydrates, and prioritizing high-fiber foods throughout the day. These aren't small, symbolic gestures. They are measurable, evidence-backed interventions that work every single day, cost nothing, and benefit your heart, your brain, and virtually every system in your body at the same time.